Good evening. Thank you for joining our educational program on bronchial thermoplasty, sponsored by Boston Scientific. Our presenters this evening are Dr. Michael Schatz and Dr. Mario Castro. Dr. Michael Schatz is an allergist at Kaiser Permanente Medical Center in San Diego, California. Dr. Schatz is a past president of QuadAI and the editor-in-chief of the Journal of Allergy and Clinical Immunology in Practice, a new QuadAI publication set to launch in early 2013. Dr. Mario Castro is a professor of medicine and pediatrics in the Division of Pulmonary and Critical Care Medicine at Washington University School of Medicine and is currently performing bronchial thermoplasty in St. Louis, Missouri. Dr. Castro was the principal investigator and lead author of the AIR-2 pivotal study for the safety and efficacy of the Alair bronchial thermoplasty system. Thank you again for joining us, and I will now pass the program on to Dr. Michael Schatz.
Thank you, Debbie, and good afternoon, good evening, depending on where you are. The agenda is shown here. I'm going to start and talk about severe asthma in general, and then turn it over to Mario, who will talk about bronchial thermoplasty specifically, an overview, an update on some of the recent safety and effectiveness data, and then more targeted information about patient selection and management, and then we will all participate in the question and answer session when we do hope to leave plenty of time for questions and answers. As you all know, asthma is one of the most common and costly diseases in the world. The prevalence of asthma has grown in recent decades, with almost 25 million people living with asthma here in the United States and more than 300 million people worldwide. And not only is asthma common, but as you know, it has substantial impact. In 2007, asthma attacks led to 1.8 million emergency room visits, 456,000 hospitalizations, and more than 3,400 asthma-related deaths. And all of this translates into an estimated $20.7 billion in annual direct and indirect healthcare costs. Just this month, the Asthma and Allergy Foundation of America released its annual Asthma Capitals for 2012 of the top 100 most challenging places to live with asthma in the United States. This is actually done quite scientifically. It's based on prevalence factors, risk factors such as allergens, air quality and access to care, and number of asthma specialists. And as you see, these 100 locations are well distributed in the United States. The slide shows the top 10, but clearly asthma is a nationwide epidemic. It is certainly well known that asthma varies in severity, and not surprisingly, the impact of asthma increases with the severity of the disease. In particular, the resources and costs associated with managing more severe asthma increase exponentially. It's estimated that 5 to 10% of the asthma population have severe asthma that requires increased resources, and often, in spite of all of these resources, remains difficult to manage with conventional asthma treatment. The major goal, of course, of asthma therapy is to achieve and maintain asthma control, which translates into reducing impairment and future risk. Impairment includes symptoms, day and nighttime symptoms, reliever therapy, activity limitation, and lung function. Reducing risk is reducing the risk of exacerbations, loss of lung function, and reducing medication side effects. Standard medical therapy requires adherence and can have serious side effects. And again, this subset of severe asthmatics often remain not well controlled despite maximum current therapy. As we know from the Asthma Guidelines, a stepwise approach to managing asthma and achieving control is recommended for the severe asthma patient population who are still not well controlled with standard therapy. That would be step 5 and step 6 therapy. Additional treatment options are needed. Since 2010, a treatment approach to target excessive airway smooth muscle has become available with bronchial thermoplasty. The concept of bronchial thermoplasty is to reduce this excessive airway smooth muscle, which is thicker and more sensitive to triggers in severe asthmatic patients. By reducing airway smooth muscle, bronchial thermoplasty has been shown to reduce bronchoconstriction, which has resulted in reduced asthma exacerbations and improved quality of life, as you'll hear more later. And so as we clinicians, bronchial thermoplasty is an important option to consider for this group of severe patients who aren't well controlled with standard therapy. And so with that introduction, I'm going to be turning this over to Mario to provide much more detail about bronchial thermoplasty. But before that, we have a polling question.
Great. Thank you, Michael, for that introduction, and thank you for all the attendees, and hopefully you will catch some information tonight. What I'll be talking about next here is bronchial thermoplasty treatment, and then also delve into patient selection. And of course, we won't be able to go into a lot of these things in great details, but as you'll note here, there are a number of references. If you'd like to get additional information, you'll be able to go to this. So if we'll start on slide 12, what is bronchial thermoplasty? It is an outpatient bronchoscopy procedure in which we introduce a catheter through the working channel of the bronchoscope. And through that catheter, we're able to deliver heat to the airway walls in the lungs. This heat reduces that smooth muscle, which Michael had spoken about earlier, and this therefore limits that ability of that smooth muscle to contract, which leads to patient symptomatology and asthma exacerbations. This is a treatment that's indicated for those that are on high doses of inhaled steroids and long-acting beta agonist. And as we demonstrated in the pivotal trials, this improved overall asthma control and improved quality of life for patients with severe asthma. And importantly, it's a complementary treatment for our patients in that they still need to take their medications in terms of their controllers and their rescue medications, but it's really meant to improve their overall control as opposed to being a replacement. If we go to slide 13, you'll note on slide 13 that this is a video demonstrating the bronchoscopic procedure, and as the bronchoscope is advanced into the right lower lobe, the catheter will be introduced through that working channel, and it will go down into the smaller airways. These are usually down to the 4th, 5th generation airways. And this will then deliver that heat up to 65 degrees Celsius. You can see that blanching in the video there. And that's over approximately a 5 millimeter space. And then the bronchoscopist pulls that catheter back. You'll note that there's also some black bands on that catheter that indicate exactly where that space is so that the pulmonologist can visualize that. Once you treat a subsegmental level, you will withdraw the catheter, and then you'll advance it into the other segment, and you'll keep on treating those subsegmental levels all the way back to the main bronchi. This is an outpatient procedure that's done under moderate sedation with typical sedation that we use in outpatient bronchoscopy. And it's performed over 3 sessions in which we'll treat first the right lower lobe, then the left lower lobe, and then both upper lobes. Each of these sessions are spaced out approximately 3 weeks apart. So if we go to slide 14, you'll actually see a live case being treated, a patient being treated, in which the catheter is advanced to the right lower lobe, and then the basket is expanded so that it meets contact with the bronchial wall. And then once it makes contact, the bronchoscopist is able to activate that catheter. And you can't hear it here on tonight's call, but there's some beeps that are sounding as that energy is being delivered. And then you'll see that they brought the catheter back and repositioned it, and then again activated the catheter. Now, with each of these treatments that we do, each one of these treatment sessions, we'll do anywhere from 60 to 80 to even 100 activations. These activations really depended on how many subsegments do you have, and that varies from individual to individual. But you want to treat all the subsegments that you can reach with this catheter. We do know that with this treatment that the airway wall itself will reheal itself or regenerate quickly. In fact, when I go back for the second or third treatment, I always inspect the other sides that I've done. And you will see that that epithelium has basically gone back to normal once you look at that. The other important thing to note here is that now through at least 2 different studies, we now have CAT scans out to 5 years, and we have demonstrated that there are no structural changes. There's no evidence of any bronchiectasis or anything else that has developed in these patients over a long period of time. So let's go on to slide 15. And slide 15 is really the best data that we have in how bronchial thermoplasty would work in our patients. And this is based on the preclinical data that was performed in using a dog model. And as noted here is a transection of an airway in an untreated case, and then the same case 3 years later. And you'll note that the airway smooth muscle is in those little bundles right below the lamina reticularis in the airway epithelium there. And you'll note that those bundles are missing in the picture on the right. And this is accentuated with the trichome stain. Now let's go to the next slide, which is slide 16. And this is a very interesting case where, again, in a dog model, you'll see that methacholine will be instilled in the airway on the left and then on the airway on the right. And what's different is that the airway on the left has been treated with bronchial thermoplasty, whereas the airway on the right was not treated. And you'll note at the end of the video here that there's marked bronchoconstriction that occurred in that airway on the right, whereas the airway on the left that received the bronchial thermoplasty doesn't have that same marked bronchoconstriction. And this model was actually utilized in the preclinical studies and actually to decide exactly how much treatment or how much heat or energy do we need to apply to the airway in order to prevent this bronchoconstrictive response. And that's what's demonstrated in this slide. So let's go on to slide 17. This is really an algorithm of how we go about doing bronchial thermoplasty. As mentioned earlier, we do this in 3 separate bronchoscopies to treat different sections of the lung. We will treat the right lower lobe, let the patient recover for about 3 weeks, treat the left lower lobe, and then the last session we'll do both upper lobes. We have not treated the right middle lobe because of just historical precedence. There's not been any complication that we know of in terms of the right middle lobe. We know that this spacing out of 2 or 3 weeks allows the patient to fully recover from the procedure, and it minimizes any adverse effects that are related to the procedure itself. This also allows the treatment sessions to be less than 1 hour, and therefore, again, trying to minimize the complications that occur. The other nice thing about this figure is it helps those that don't know their anatomy as well, or the fellows that are learning that they can understand, what the bronchial anatomy is. And you have to be very meticulous, I think, in terms of tracking exactly where you're at, and we actually will mark the activations on the sheet to track exactly where we've been and what we're treating. On the next slide, we're going to go over the procedure itself. in terms of preparation for the procedure, and then the operative and postoperative care. And what's noted here is that first, we do need to evaluate these patients very carefully. This can be done by yourself if you have expertise in asthma. Can be done by one of your colleagues in pulmonary or allergy, or somebody that has expertise in asthma. And that includes an extensive evaluation to make sure that that patient does indeed have asthma, that they do indeed have severe persistent asthma that is not controlled under treatment with high-dose inhaled steroids and long-acting corticosteroids, and making sure that there's no other contraindication for the procedure. Once we deem that necessary, then we go ahead and schedule the case, and we instruct the patient to take oral prednisone 3 days prior to the procedure, 50 milligram dose in adults, and this is done for 3 days prior, the day of, and then the day after the procedure. That may be modified as you see necessary in those patients that are on chronic oral corticosteroids. Now, during the procedure, one last thing in terms of prior to the procedure, prior to the bronchoscopy, which is a little bit different than in the usual bronchoscopy case, we do measure spirometry. So we do a pre-bronchial thermoplasty treatment spirometry that can be done post-bronchodilator in order to see what that patient's function is on that day. And it helps you compare to their prior measurements in the clinic, and lets you be assured that you can move on with the thermoplasty for that day. And we also will do that on the second and third treatment sessions. Then with the bronchoscopy itself, during that treatment, we use topical anesthesia. Usually this is lidocaine in the upper airway and then below the vocal cords in aliquots. We will pre-medicate the patient with 2.5 milligrams of albuterol via nebulizer prior to the procedure so that they will be maximally bronchodilated. We will then proceed with the case. So the patient may just be intubated with a bronchoscope or can utilize a support of the upper airway such as laryngeal mask anesthesia in order to protect the upper airway. During the case, we do use moderate levels of sedation to keep the patient comfortable throughout the procedure and try to minimize cough and movement, especially during the activations that are being done. Once the catheter is in place, the energy is delivered just with a simple step on a pedal, which activates the radiofrequency controller device that's attached to the catheter. And this, again, delivers heat at 65 degrees Celsius for 10 seconds. As the patient moves throughout the procedure or starts to cough in the middle of this activation, the catheter will lose contact and it will shut off the delivery of that energy. Again, most procedures will take about 60 activations, maybe more in the upper lobes since you have more area to cover, usually 80 to 100 activations. And this can be accomplished within an hour. The patient does need to be monitored then after the treatment for 2 to 4 hours. We will typically start another albuterol nebulizer in the patient immediately in the bronch suite after the treatment or in the recovery area. We will monitor that patient with typical criteria that we use post-bronchoscopy, and then we will check their lung function again prior to discharge to make sure that their lung function is stable and within 80% of that pre-procedure post-bronchodilator FEV1. We then arrange for the patient to have a follow-up visit, usually 2 to 3 weeks later. This is right before their next procedure. And then we will arrange for a follow-up phone call the day after, 2 days after, and 7 days after in order to make sure that the patient is doing well after the treatment itself. So let's go on now. That's the information about the procedure itself. Let's go on to discuss the clinical data in terms of its effectiveness, but also speak about some newer data in terms of long-term safety and effectiveness. So on slide 20 is a summary of the clinical data to date that has been published in bronchial thermoplasty. You can note here that over 4 peer-reviewed publications have come out of the trials performed for bronchial thermoplasty that led to its approval, and the largest one was the AIR2 study. This led to almost 300 patients being treated across these studies. Over 800 procedures were performed. And really the case for the bronchial thermoplasty was carefully built upon this background, where the initial study on the bottom bar there, which is called feasibility, was really just a small study to test the feasibility done by my colleague Jerry Cox, or led by my colleague Jerry Cox. And then this led to the first controlled study that was published in the New England Journal of Medicine, the AIR1 study. These were moderate to severe patients and really built, again, the case for safety as well as effectiveness in terms of this treatment. This was then followed by a study led by Ian Pavord, which was a much smaller study, which was focused on patients with severe, or really a subset of very severe patients with asthma, where almost half of those patients were on oral corticosteroids. This was followed then by the AIR2 study, in which we limited the treatment to patients with severe persistent asthma on high-dose inhaled corticosteroids that had a pre-bronchodilator FEV1 of greater than 60%, and had to meet certain criteria in terms of symptoms. You'll note that this studies all build over an extensive period of time now, over 10 years, and you can see that in the gray bars there that these patients not only participated in their studies, but those that received the treatment are actually entered into an extension study, and they are being followed for safety. So now we have experience with bronchial thermoplasty for over the past decade in these patients that were treated in the early 2000s. So the next slide leads into more detail about the pivotal study, which was the AIR2 study. In this study, the primary endpoint was asthma quality of life. This was a patient-centered outcome that, in discussion with the FDA, we decided upon to be the primary endpoint. We set up the trial in a very novel design in that it was a double-blind study, but the control arm here was sham-controlled. So for every 3 patients entering the study, 2 received bronchial thermoplasty, 1 received sham bronchoscopy. And those that received bronchial thermoplasty, they received the thermoplasty just like we spoke about in terms of the 3 procedures. And then the sham group also received a bronchoscopy. In the catheter was introduced and activated just like in the other group, but the only difference was that the energy was not released through that catheter. The treatment team was separate from the assessment team. Therefore, the bronchoscopist could tell, if that energy was going across, just like in that video that we saw earlier where we saw some blanching of the mucosa. But they did not participate at all in the assessment of any of the endpoints for the study. And as noted here, this was almost 300 patients enrolled over 30 centers across 6 countries. And the primary endpoint was based upon a 1-year follow-up. And now all patients have completed a 5-year safety follow-up. So this next slide summarizes the outcomes from the AIR2 study. The primary endpoint is the Asthma-Related Quality of Life score, which is a validated questionnaire that's been developed across clinical trials. And using that instrument, previously has been reported that you need to have at least a 0.5 change in that score. And this is a scale from 0 to 7, with everybody entering the study on average around 4. Now, at the end of the study, the primary endpoints was based upon the results of that score at 6, 9, and 12 months. 79% of patients, or 4 out of 5 patients that received the bronchial thermoplasty, achieved that improvement in the minimally important difference in the asthma quality of life score. And this compares to about 63% in the control group, which was the sham bronchoscopy group. This was a statistically significant change in the asthma-related quality of life score, and so therefore the primary endpoint was met. But even more importantly are the results from the secondary outcomes that we'll summarize next, which was there was a 32% reduction in severe exacerbations, these are exacerbations that require oral corticosteroids or doubling the ICS dose. And remarkably, there was an 84% reduction in emergency room visits for asthma symptoms. There was a 73% reduction in hospitalizations. And then lastly, there was a 66% reduction in lost days from work and school, importantly impacting on these patients' productivity in terms of their normal daily life. There were really no unanticipated adverse events related to the thermoplasty, and we'll talk about next year the long-term results from the trial. And what was published last year is demonstrated here, and that those patients that received the bronchial thermoplasty then participated in this extension phase. And what we demonstrate here are the results in regards to severe exacerbations, those exacerbations requiring oral steroids. You'll note in the light blue bar is the baseline report for severe exacerbations in the year prior. The gray bar is the results from the primary study, from the AIR2 study, showing a significant reduction in those severe exacerbations down to 30.9%. And then lastly is the new data, which is the year 2 results. Those same group of patients that received the bronchial thermoplasty 2 years later after the treatment were down to 23% that had experienced a severe exacerbation. And as noted there in the footnote, there was no statistical difference between the year 1 results and year 2 results. Therefore, these results, as well as results in terms of healthcare utilization for hospitalizations and ED visits, which again showed a sustained reduction at year 2, demonstrate that this treatment is really a disease-modifying effect for the smooth muscle around the airway, and that smooth muscle is not returning, at least represented by the clinical outcomes here, that there's no really increase in these events after now almost 2 years. And of course, we'll be sharing results subsequently once the results are calculated for the 5-year results. So let's move on to slide 24. And this really summarizes adverse events related to bronchial thermoplasty or the side effects. We noted there was no device-related procedures, none of these bad things listed here in terms of pneumothorax or any of those types of events. There was an increase in adverse events reported in those patients that received bronchial thermoplasty around the time of the procedure. So this was in the 12 weeks, which we call the procedural treatment period around the 3 bronchoscopies. The most common respiratory adverse event was an increase in their asthma symptoms. These typically occurred within a day or 2 of the treatment and resolved within a week with standard care, which included bronchodilators and systemic corticosteroids. Now, in the long term, this whole event profile basically flips in that those that receive bronchial thermoplasty now have decreased adverse events, respiratory adverse events, asthma symptoms, hospitalizations, and ER visits after they recover from that 6 weeks after that last treatment. And again, that corresponds to kind of what you should educate your patients is that this treatment, you need to go through all 3 treatments and recover from that treatment before you start seeing meaningful improvements in the symptoms and before you start reducing any medications that they may have been on. The last point here, again, reiterates what we discussed earlier in that we have now followed these patients for 5 years. In the AIR1 study, and the references there, shows that there was stable lung function in those patients. And as noted in the other reference, there were no evidence of any structural changes or evidence of bronchiectasis on CAT scans. So this long-term safety data is now quite reassuring. So the next slide is a very interesting result from the AIR2 study that in this, with the questionnaire, we asked the patients, not in the presence of the investigator or anything like that, we asked them, do you believe that you would do this again? And then lastly, in the green, would you recommend it to a family member in terms of treatment? And what's noted here is that in the AIR2 study, our patients described that definitely, yes, they would undergo this again, and they would recommend it to a family member. And you can see a significant proportion of the other patients said probably yes as well. So this, speaks to the high satisfaction that patients have that receive bronchial thermoplasty. So let's finish off with talking about patient selection and management. On slide 27, when we select patients, again, we follow the typical guidelines for the National Asthma Guidelines, in that we select patients with severe persistent asthma. But as noted here, we also want to consider in our patients, as the guidelines state, their level of asthma control. And for those patients that are not able to achieve control with high-dose inhaled corticosteroids and long-acting beta agonist, you want to select those patients in that not well-controlled or very poorly controlled group. If you're using an instrument such as the ACT, this would correspond to a score that's less than 20. Now, as noted here also is patients that you may select preferentially for this would be those that have had a history of exacerbations, 2 or more exacerbations in the previous year requiring oral corticosteroids. This identifies a patient that truly has severe persistent asthma that is uncontrolled and would benefit potentially from bronchial thermoplasty. I do want to note here is that it's important that you've addressed adherence with your patients. This is not a treatment for non-adherent patients. These are patients that have demonstrated adherence and have really taken the maximally tolerated medication for their disease and have not achieved that control. So let's move on to slide 28. What patients do you not want to do bronchial thermoplasty in? And the contraindications are relatively brief, as noted here. Of course, because of the energy that we use, you want to avoid this in any patient that has an implanted device, such as a pacemaker or an AICD. You want to avoid those patients that have known sensitivity to medications that you would be using in the bronchoscopy. And you want to avoid patients that have been previously treated with the LAIR system. And in fact, no patient, to my knowledge, has ever been retreated or required that retreatment with bronchial thermoplasty. As noted in this next slide now is the precautions. So these are patients that are not necessarily contraindicated, but you may want to delay their treatment. Those that have had an acute respiratory infection, usually within the last couple weeks. Those patients that have had a change in their oral corticosteroids in the last 14 days, those that have had known bleeding disorder, and those that are unable to stop taking their anticoagulant or the antiplatelet medication or NSAIDs before the procedure. In those patients, again, you may want to work with their referring physician or cardiologist to see if they can come off at some point those medications to proceed with the bronchial thermoplasty. So let's go to slide 30, and we're going to talk about the post-bronchial thermoplasty management. And as noted here, we will typically follow up that patient to make sure that they're recovered from the procedure, that there's no adverse consequence from the procedure that needs to be addressed. And then we'll return their care back to whoever their primary asthma physician is for ongoing management. Again, we want to make sure that there's a period of time, usually about 6 weeks after that last treatment, that you allow that patient to fully recover and then measure their control, their level of control, reassess their lung function, and decide whether or not you can start to reduce medication depending on that level of asthma control at that point. On the next slide, we're going to talk about a real patient that actually received the bronchial thermoplasty at our site here in St. Louis. And in this case, she was a 27-year-old female with severe persistent asthma since childhood. She had been taking high doses of inhaled corticosteroid, here is noted, fluticasone and salmeterol. She had been using her beta agonist 2-3 times a day. And as noted here, she had very few days that were symptom-free. Only 18% of the days were she without symptoms. And what really prompted her to kind of consider alternative treatments was that she had a severe exacerbation that landed her into the emergency room where she had to go on systemic steroids and had previously also 2 unscheduled office visits as well. She had been very active up to that point and in fact was active in collegiate sports. And then because of her severe asthma and starting to impair her life, she was starting to miss work as well, and clearly was not satisfied with her level of control. Now, as noted here in our examination, her breath sounds were clear. She was not actively wheezing at the time of our assessment, and her lung function was well preserved, as noted here, 108% of predictive for FEV1 pre-bronchodilator. I should note that in this particular case, her lung function was well preserved, but in a lot of cases that we have done, we have gone to much lower levels of FEV1, even as low as 40% of predicted pre-bronchodilator. Though I do want to say in terms of that level of FEV1, that really should not be the first patients that are treated at a new center, that a center that's starting with bronchial thermoplasty should really keep in the AIR2 criteria in mind and really gain experience with those type of patients, which again was a pre-bronchodilator FEV1 of 60% or post-bronchodilator of 65% of predicted. So in our particular case, you can see the results on the next slide. She reported no pain associated with the treatment, though she did have an increase in coughing and wheezing associated with each procedure, and this responded to bronchodilators and the corticosteroids which she was taking the day after. 2 years post-procedure, she has had no asthma exacerbations, no visits to the emergency room, and in fact I can update this now. She's done her 5-year follow-up, and again, those are true. And I'm happy to say that her quality of life has improved remarkably. She's now been able to run 2 half marathons and has not had to use her inhaler during the running event. So we'd like to end with always a difficult subject, which is coverage policies. And as noted here, is that it's advised that providers that are seeking to get this treatment for their patients, that they seek a written predetermination for bronchial thermoplasty before performing the procedure. And as we know, with most payers, often this may have to be done 1, 2, and even 3 times before you're able to successfully get that coverage. It has been approved through predetermination in many cases throughout the U.S. At this point, it's still done on a case-by-case basis on those insurance payers that have non-coverage policies, but that should not deter a provider from really advocating for their patient to get this approved. There are commercial payers now that are starting to coverage this treatment across a couple states, and we're hoping that again that with the demand from providers that this will continue to increase over time. And I take this back to when new therapies come out, such as anti-IG therapy when it first came out. Again, there was a struggle that we had to go through in order to get that treatment approved by insurance companies. But now, it's less cumbersome. And our hope, again, is that over time, that insurance companies will start to have coverage policies for bronchial thermoplasty. And as listed here, there is a number for contacting if you would like assistance in terms of bronchial thermoplasty coverage or seeking coverage or reimbursement for your patients. So at this time, I think we are going to post one more question, and we'll turn it over for a Q&A session. Thank you.
So question number 1, how do you assess or evaluate a patient as a candidate for bronchial thermoplasty?
Yeah. So I mean, I do think it starts by what Mario alluded to before, to make sure that you're really giving this patient everything else that's available, and that means confirming the diagnosis. It means identifying important triggers that could be modified environmentally, treating comorbidities, assessing adherence, using the various controllers that are available, and then following up and determining that in spite of all of that, this patient is not well controlled. And I think for the patient where all of those modifying factors are addressed and the diagnosis is confirmed, and you have reason to believe that the patient is taking the various combination of medicines that are available, then and still not controlled, that would certainly be one group that I think would be very good candidates for consideration of bronchial thermoplasty. I think the other group of patients are the ones who can be controlled but are requiring regular oral prednisone to do so, where even though they're getting, of course, the benefits, there are those risks. And that would be, and again, assuming all these other aspects of their care has been optimized, and they're still needing regular prednisone for control, I think there also the benefit-risk considerations would make one at least want to consider a bronchial thermoplasty. So that would be my answer. And Mario, what would you add to that?
Yeah, I think that's excellent, Michael, in terms of selecting that appropriate patient. I would think in terms of actual assessment tools that I use, of course, a full pulmonary function test, including spirometry, lung volumes, and diffusion capacity. I want to make sure that that patient doesn't have evidence of emphysema. And also, of course, allows you to kind of measure their FEV1 and assess that. We also routinely perform chest computer tomography to evaluate the airways in that patient, but also to make sure that they don't have any structural issues, that there's no parenchymal damage, such as seen from emphysema or bronchiectasis. Those patients you want to exclude from bronchial thermoplasty. I do think one of the questions someone has posed is to use certain questionnaires to evaluate their stage, and I do at our clinic. We use the asthma control test, but the ACQ can also be utilized. And I think that's helpful from the standpoint of looking at your patient's response in your own clinic. And in fact, a number of my colleagues that I've talked about this procedure that have treated patients in their practice, even in the community, where they're tracking their patients, their ACT or their ACQ scores over time, and see what happens to these patients with the bronchial thermoplasty, and see some amazing results in that regard.
Thank you, Dr. Castro and Dr. Schatz. Another question we have is, how about BT for those patients with overlap with COPD and asthma?
Yeah, I think I would say no, that I don't think that we should be treating patients with COPD and asthma. And by that I mean specifically those patients that have emphysema and evidence of chronic bronchitis, most often due to cigarette smoke exposure. I think that I say that because we really don't have much experience with patients with emphysema, what happens to the airways once you reduce the smooth muscle, and what happens to that lung parenchyma and their dynamic compliance. I do want to mention, though, that I do see some patients that have this label of asthma/COPD, and I think most clinicians are sometimes referring to also patients that have severe asthma, that have chronic airflow obstruction, or airway remodeling where they don't have bronchodilator reversibility.
Thank you, Dr. Castro. Next question is, what changes in medications have you seen in your patients after bronchial thermoplasty?
Well, I'll start there, Michael. I've been able to reduce patients' inhaled steroid dose and oral steroid dose. Our practice is really to try to tackle the oral steroid dose first once that patient's fully recovered from their bronchial thermoplasty. And that's a gradual reduction. As you can imagine, most of these patients have been on oral steroids for a number of months to years. But even those patients not on oral steroids, I will actively start to try to reduce their inhaled steroid dose in order to minimize side effects from their inhaled steroids. I will try to minimize that dose to a minimum amount possible, but I do keep in mind that they do need an anti-inflammatory therapy that's kept on board long term. we have been successful in removing other medications, add-on medications in these patients, such as their long-acting beta-agonist, removing their anti-AG therapy. So these other medications can certainly be removed in your patients post-bronchial thermoplasty, and in fact that's happened with our case that we talked about earlier today.
Yes, and I would just say that as you're implying, it's not going to eliminate all medicine, but certainly aside from improving the ability to achieve control, it definitely has a great potential to reduce the total medicine burden for a patient.
Okay, and the next question is, what is the percentage of patients requiring hospital admission after bronchial thermoplasty?
So we demonstrated in the AIR-2 trial that approximately 3% of patients required hospitalization due to respiratory symptoms after a bronchial thermoplasty treatment. This was a cumulative risk, and therefore after all three treatments there was a total hospital admission risk of about 10% that occurred after bronchial thermoplasty. I do discuss that ahead of time with my patients to make sure that they understand that they understand that there will be more often than not a worsening of their asthma symptoms with the bronchial thermoplasty that usually occurs again within a day or two of each treatment and resolves within a week. There's also this risk of admission, and I think for some patients, that are in the hospital pretty frequently, this is not an issue. But in the patient that that's a rare event, that has to be taken into consideration.
Dr. Castro, another question: does bronchial thermoplasty decrease pulmonary eosinophil count?
Sure. So we do not have any data to answer that question at this point. We have not performed airway biopsies in these patients during the study or after the study, as long as they were enrolled in the study, because of the potential complication from bronchial biopsy itself. We are conducting a study now to look at sputum eosinophilia, measuring it before the treatment and then following after the treatment to look at its impact, and we're still too early in that study to really to know the answer to this question.
And I would just say that I know that questions like that and other questions of whether there are subsets of patients based on physiology and whether that's or immunology, whether that's atopy, whether that's exhaled nitric oxide, as you say, sputum eosinophilia, how those serve as markers of either responders or response are important questions, and they're the subjects of ongoing investigation.
Great. Another question is, can you address the concerns that some have around the long-term effects of bronchial thermoplasty with patients?
Yeah, I think the best data is we discussed has now come from the 2-year results that we published in the Annals, as well as the 5-year results from the AIR-1 study and the RESA study, where we've shown that in terms of lung function, that lung function is stable long-term in patients that receive bronchial thermoplasty. We have demonstrated by CAT scans that there was no structural damage that occurred in the airway in these patients. And this CAT scan study I'm referring to in the AIR-2 study was a pretty large study. 100 of the patients that received bronchial thermoplasty were followed at baseline 1 year, 3 years, and 5 years with CAT scans, and there were 50 patients in the sham group that were followed. And therefore, we know that, based on this data, that there is really reassurance that there's no structural issues that occur. And in fact, some of the initial patients in the feasibility study are now followed out over 10 years. And Dr. Cox has commented that these patients maintain their long-term control that they achieved with the bronchial thermoplasty.
Okay, another question. What patients, Dr. Kasser, would you not perform bronchial thermoplasty that meet Dr. Schott's criteria, such as diabetics, smoker, aspirin-sensitive patients?
Sure, I think it's an important question, and I would say that we have to use our clinical judgment, and that any of these comorbid conditions, you have to decide, are they adequately controlled, and could you go ahead with the bronchial thermoplasty as long as they're adequately controlled? And in fact, today I did a case, a patient with severe persistent asthma who had underlying diabetes, type 2 diabetes, insulin requiring, and we just monitored his glucose level pre-procedure and post-procedure and adjusted him with insulin as needed to make sure that he was safely treated with the bronchial thermoplasty. So I don't think that that's a contraindication. I do think in terms of hypogammaglobulinemia, the main concern I would have there is whether or not they have underlying bronchiectasis associated with that. If they're just a common variable immunodeficiency without underlying bronchiectasis, then I think it would be okay. But I would think you would have to take in consideration the frequency of their respiratory tract infections and whether or not they have any structural issues present on CAT scan. But if they do have significant underlying bronchiectasis, I would not treat them because the concern there would be that they have bronchial artery enlargement that goes along with bronchiectasis, and that the heat treatment may cause undue complications in terms of bleeding. And in terms of your last group of patients, the smoking asthmatic, we purposefully excluded those patients from bronchial thermoplasty in the trials. If they were active smokers or they had greater than 10 years of smoking, we excluded them. I do think that similar criteria can be applied in your clinic, and I can tell you on my own experience that I want patients to not have been actively smoking at least for a year prior to the treatment. Want them to make sure that they're fully recovered from whatever damage may be done from the smoking, and want to prove that they don't have emphysema or destructive changes from that. So I don't think it's an absolute contraindication, because, as we know, out there in the population of asthmatics, that about 20 to 25% of them do smoke, or approximately, depending. I'm sure that varies quite a bit from area to area. And so I think that as long as they have not developed progressive parenchymal disease from that, that they potentially would be a candidate as long as they can comply with smoking. And I'd be interested in hearing Michael's comments in that regard.
Yes, and I agree with that. I mean, I think that this obviously the smoker represents a bit of a question, but we also know that those patients tend to be less responsive to some of the medicines we use. So I could imagine there being some patients doing the best they can with smoking, as you say, no evidence of true emphysema, where still it would be worth providing them that potential benefit. The one other group that was mentioned, the aspirin-sensitive phenotype, I would make 2 points. Number one, I wouldn't hesitate to refer such a patient who otherwise met the criteria. They do have the added opportunity of aspirin desensitization as an intervention to try to improve their outcomes. But again, if everything else has been done for that group of patients, I wouldn't hesitate to refer it, but then I would ask you, Mario, would you agree with that? Have you had any experience with aspirin-sensitive patients, and is there any reason why I should be more cautious?
No, I agree with you, Michael. I have had patients with Samter's triad that have had upper airway chronic sinusitis, nasal polyposis, and aspirin sensitivity, and we have treated those patients as well, and do not believe that that those patients do any worse in terms of the bronchial thermoplasty as well.
All right, we've had some great questions. We have time for 2 more. Next question is, in terms of methacholine challenge, do you think that would be useful to do that or necessary for patients that are being considered for bronchial thermoplasty?
I'll just say a couple things, and obviously turn it back to you, Mario. When we talk about confirming the diagnosis, I guess I could imagine some circumstances where one would need to do that to confirm the diagnosis. It seems that many of these patients wouldn't get to that point. But so I think the main usefulness of it, at least as is now defined, would be in confirming the diagnosis. Again, we're finding that when we do the exhaled nitric oxide in patients with a questionable diagnosis, that's often turning out to be very, very helpful. So I think that in that phase it would. The question has always been, or not always, but has been raised for a while, whether monitoring patients and seeing how they change in terms of their bronchial hyperreactivity helps you know anything more about them clinically. And so that question could be extended to, would that help you identify good responders or poor responders based on not the diagnosis, but their degree of bronchial hyperreactivity? And I don't know of any information that informs that question, but then I would turn it back to you, Mario.
Sure. I do find methacholine challenge helpful, or some bronchoprovocation study in the initial evaluation. These patients are often pretty severe, have seen multiple specialists, on multiple medications, and you don't know, what's underlying things often, and so I'd like to have some objective evidence that they do have airway hyperreactivity. And so that may be just demonstration of variable airflow obstruction, or maybe a methacholine, or maybe an exercise challenge. It's just helpful information. Make sure that, for example, if they have vocal cord dysfunction, just make sure that that's not their sole problem and they really don't have underlying asthma before we go through a treatment with bronchial thermoplasty. I do want to keep in mind that our group just published this paper on methacholine bronchoprovocation challenge testing in the Journal of Allergy and Clinical Immunology, and showed that the sensitivity of that test was only 77%. And therefore, it doesn't exclude the diagnosis totally, but it does help you in the situation where it's positive and you have confirmatory, you have a good clinical history, and confirmatory tests like that would be helpful in that setting.
Okay, and the last question for this evening is, those patients with allergy-related asthma who are on Xolair, or currently being treated with Xolair, do you think that this medication may be removed after BT?
Well, I know, actually, I think Mario mentioned that there are patients where that has been. I have sort of thought, as have others, that one very interesting real-world study would be to compare those two treatments in patients who get to that point. But I'm not sure that'll be done very, very soon. But Mario, did I hear you correctly that you have had some patients where Xolair has been removed after bronchial thermoplasty?
Yes. Yeah, and it's, I think, for our patients that we've had on it, say for 6-12 months, and they've not demonstrated any objective response to it, or even subjective response to it, I think it's certainly reasonable to stop the medication at that point and go ahead with the bronchial thermoplasty. But I think, again, that has to be in conjunction with whoever their asthma doctor is, and making sure that that's something that they don't need for other reasons as well.
Yes, this concludes our Q&A session. So before we end, Dr. Schatz, would you like to say any closing remarks?
Yes, only to, again, thank the participants and hope we've met your goals. The question that was posed, 50% of you said patients had been asking about this, so I certainly hope that this allows you to better answer your patients when they question about bronchial thermoplasty. But most importantly, I think I hope this will help you know when to think about bronchial thermoplasty in your armamentarium. And certainly there have been tremendous progress made over the past 10 to 20 years in terms of treating asthma, but there still is this subgroup of patients either not controllable with current treatments or requiring, dangerous doses of medicine, that this, I think, does offer a very, very important option for. And again, I hope that this presentation has helped you better understand where that fits in and when and how to offer that to your patients.
Thank you, Dr. Schatz and Dr. Castro. This concludes our program. Thank you, everyone, for attending, and have a good evening.